Welcome to GIE Author Interview Series. Today, we're honored to have Dr. Todd Baron, Professor of Medicine and Director of Advanced Endoscopy at University of North Carolina in Chapel Hill. Welcome, Todd.
Thank you.
Thank you. So Todd's paper is EUS-guided Hepaticoenterostomy as a portal to allow definitive antegrade treatment of benign biliary diseases in patients with surgically altered anatomy. So Todd, explain to us the rationale and what these patients are up against when they have these.
Okay. So I've actually always had an interest in patients with surgically altered anatomy with retrograde approaches. I was an early adopter of using colonoscopes even before single balloon scopes. But as you know, that's a very cumbersome way. They can be very technically difficult, and if you use single balloon scopes, and while there is a therapeutic channel, and one company has a therapeutic channel short scope, you're using a long scope, the accessories are limited, the channel diameter is limited, and of course, they can be extremely time consuming. So my thought was, well, interventional radiologists treat benign biliary disease all the time by doing transhepatic punctures, and they do therapy downstream from where the puncture is. So the puncture for them is really just the access point to treat disease that's really downstream from their puncture site. So I thought this could really be a similar thing that we could do endoscopically with avoiding percutaneous drains. And so I happened to just see a fair amount of patients with post-surgical anatomy that are referred to me for therapy, and I began doing this type of approach.
Mm-hmm. Was there any new device that came or new stent that roused your interest, or was there current methods are just not good enough?
Right. Well, a couple things. Well, the first patient, as I recall, was a young woman who actually had a liver transplant at an early age for biliary atresia, and we couldn't reach, even with a single balloon scope, her hepaticoenterostomy. So she had a hepatico-jejunal stricture, and so we had discussed with the team and with the patient if they were willing to have and then she had, let me preface it by saying, in the past she had a percutaneous drain. She had some learning disabilities and some difficulties, and poorly tolerated a percutaneous drain for a stricture. So it really was not adequately treated, and her family said they never wanted to have another percutaneous drain in that patient. And we tried, like I said, with a single balloon scope and couldn't reach underneath to get to her anastomotic stricture, so we decided to do that approach, and then after that I started getting more patients. But in terms of accessories and devices, we still don't really have, or what I'm using is not really dedicated devices for this. They're borrowed, meaning obviously I use a 19 gauge needle, standard biliary guide wires, dilating devices, and then fully covered metal stents so that we prevent leakage from the stomach between the liver and the stomach. But there really wasn't any single sort of device that led me to do this. It was more putting together things that we have that exist right now.
Okay. Obviously, your learning curve will not be generalizable to many, but your first few patients, what were the barriers or difficult aspects you had to master before you were comfortable with it?
Yeah. Well, the first thing is with a lot of new procedures, there's a certain amount of fear, right? Because once you puncture into the liver, into the bile duct, and then especially once you get the dilation of the tract, you realize fairly quickly that if you lose access, you may not get access back if they decompress their biliary tree into the peritoneum, and they can get bioperitonitis. So honestly, part of it was overcoming sort of the initial fear and nerves of taking something on that potentially would have very serious consequences. The other part of the learning curve, which I think probably most therapeutic ultrasonographers realize is that you have to divorce yourself from the typical endoscopic view. And what makes this easier is basically this becomes an echo procedure and a fluoroscopic procedure with an endoscopic component, the traditional view, luminal view, at the very, very end of the procedure, because as long as you maintain the compression of the endoscope against the stomach, or in some cases the esophagus or the jejunum, I'll get to that in a second, then you have stability. You have stability with the endoscope. It's only at the very end. When you start to back away to look, you uncouple your echo. What looks good endoscopically is not a good alignment by echo. And then you have a distance where you can lose the guide wire with an oblique scope. So you basically have to keep your face plastered up against the point of entry until you back up to finally deploy the stent. The other thing is the reason we call them hepaticoenterostomies, as I mentioned, is that while most of them are hepaticogastrostomies, in the Roux-en-Y patient, the puncture is often through the jejunum just beyond the gastrojejunal anastomosis. So they're actually hepaticojejunostomies, right, from the liver side into the jejunum. And we've had a couple where we actually thought the tip of the scope was just below the GE junction, but the puncture site was in the distal esophagus. So more recently, we've had some transesophageal drainage as well.
Okay. Would you like to discuss briefly the results, the findings, interesting points?
So our technical, now we didn't, I can't remember if we probably had one or two attempts that we didn't complete, not because anything went wrong with the procedure. Some patients don't have extremely dilated ducts way peripherally. They may have central obstruction and central dilation, but the periphery where you sometimes stick gets to be fairly small. So we included the technical successes. There were only a couple where we punctured, but even with breathing, if it's a very small duct, you're out of the duct before you can get the guide wire in. So once we got a guide wire down, our technical success rate was 100%. And then, as I mentioned, the stent really is a point of access to then treat other diseases. So step one was to get the stent across, and then they would come back for a second procedure to clear out stones, to dilate strictures, and to clear the bile duct. And then the end result is to remove all the hardware, because this is a benign disease and not cancer, so the stents don't stay in forever.
So it took several sessions, not just
usually 2 to 3. And the reason we didn't push it on the first session was, even if we completed the downstream therapy, they would have to come back anyway to get the stent. You have to wait at least 4 weeks to pull the stent out of the stomach when you have a mature fistula. So usually it was 2 procedures, one to get them decompressed and the other to do the therapies, depending. So we didn't have any serious adverse events. We didn't have any bile leaks. We didn't have any bleeding. Interestingly, we had one patient who I put a stent across the papilla, antegrade, developed pancreatitis, which you would, and the reason we did that is that there was a stone in the bile duct, so we wanted to protect the patient while we were coming back. So we had a stent going from the stomach through all the way down into the papilla. It was a 10 French stent, probably should have done a 7 French stent. So interestingly enough, you would think that you wouldn't get pancreatitis going antegrade, but you can. We didn't have any serious infections for the original puncture. We had a few episodes of cholangitis on subsequent procedures when we did cholangioscopy, which is a known adverse event of cholangioscopy. All the stents that were attempted to be removed were removed. At the time of the paper, there were some patients of the 20 where we hadn't completed the downstream therapy, so they still had at that time indwelling stents, but we've been able to pull out the stents with no leaks and no adverse events for removing the stent from the stomach. Most of the patients we did as outpatients remained as outpatients, and so that's something that you couldn't do if, for example, if we're comparing this to a percutaneous approach. I think certainly we have lack of external drains, and we can do this as an outpatient procedure. Now, what remains to be seen is whether this is better than a retrograde approach. I'll say that 5 of the 20 failed retrograde therapy. But what we started to do is that we became more comfortable is to just offer this as primary therapy.
On a final note, any word of advice for advanced endosonographers
That are attempting this?
who are attempting this?
Well, a couple things. Always go longer on the stent length than you think you're going to need. So in our series, most of them were 8 centimeter long stents, some were 10, but I think in general, even if you think the tract is only, say, 2 or 3 centimeters, in reality, you're compressing it with the endoscope, so that it's end up you'll be much happier with an 8 centimeter stent, even if you think it's 3 centimeters long. And always be sure that the proximal end is you have enough in the proximal end of the stomach, because we didn't get any migrations into the peritoneum after placement, meaning if it was successfully placed, none of them migrated in. But I had one recently where I thought it was farther in the stomach. It was flush with the gastric wall, and before I could bring it back, it went into the peritoneum. I was able to salvage the procedure. That's a long story, but that's my advice to, and avoid cautery, because in other studies, cautery has been shown to be one of the predictors of an adverse event. So we were able to do this all without, in the early experience, a couple cautery, but we were able to, in the method section, describe using 3, 4, 5 dilating catheters, and then balloons, and then the stents. So I think those are the keys.
Very good. You have a video, a clip of your method.
I
am
do not,
correct?
but if our readers would like one, I can provide one.
Sounds good. Well, thank you, Todd.
Thank you.
Thank you.